All right, today we're going to tackle a fascinating topic, mastoiditis. It's a really great example of how a pretty common middle ear infection can spiral into a serious clinical challenge. And getting it right requires a deep understanding of both the microbiology and the treatment options.
Okay, so here's our game plan. We'll start with an overview of the disease itself. Then we'll dive into how we actually identify the pathogen causing all the trouble. After that, we'll cover treatment protocols, touch on prevention and public health, and finally, we'll look at the potential complications if things go wrong.
First up, let's get a handle on the disease itself. What exactly is mastoiditis from a clinical standpoint?
So, at its core, mastoiditis is an inflammation of the mastoid air cells. Those are the little air pockets in the bone behind your ear. Now, the key thing to understand here is that mastoiditis rarely just pops up on its own. It's almost always a direct complication, a follow-up act to inflammation in the middle ear, what we call otitis media.
Clinically, the classic signs are pretty straightforward. You'll see pain, swelling, and redness right over that mastoid bone. But this is where things can get really serious. The infection can escalate to a much more severe form known as malignant otitis externa. Now, don't let the name fool you. It's not cancer. It's actually a nasty bone infection, an osteomyelitis of the skull base. And very often, the culprit behind this is a really tough bug to treat, Pseudomonas aeruginosa.
So, if you want to treat this effectively, you absolutely have to know what you're fighting. And that brings us from the bedside to the microbiology lab. This brings up a huge practical challenge, right? How do you get a definitive, clean sample of the bug when it's tucked away deep inside the middle ear and the mastoid bone? Well, the gold standard is a procedure where you carefully puncture the eardrum to suck out fluid directly from the middle ear. This way you bypass any contaminants from the outer ear canal. If any material is taken from the mastoid bone itself, you have to treat it like pus and specifically culture it for anaerobes, bacteria that don't need oxygen. And of course, if the patient seems really sick or their immune system is compromised, you've got to run blood cultures to check if the infection has spread into the bloodstream. So, who are the usual suspects here? Well, the cast of characters is actually quite broad. For acute infections, you're usually looking at the typical respiratory bacteria, things like Strep pneumoniae and H. influenzae. But in chronic cases, the whole picture changes. You start seeing organisms like Pseudomonas aeruginosa, Staph aureus, and even less common ones like Aloeococcus otitis. And on top of that, you can find anaerobes, fungi, and in rare cases, even the bacterium that causes tuberculosis. Okay, this is a really fascinating and super important point, especially when we're talking about lab tests. There's a major disconnect when it comes to testing susceptibility for topical agents like eardrops. You see, the lab tests are designed for systemic drugs, pills or IVs. They just can't replicate the incredibly high concentrations of antibiotics you get when you put drops directly into the ear. So a bug like Pseudomonas might be flagged as resistant on a lab report, but it could still be completely wiped out by topical treatment. It's a perfect example of why you have to interpret lab results with real clinical context. All right, a little microbiology humor for you there. Now, with our pathogens hopefully identified, we can get down to the business of treatment. So you've got your pathogen, you know what it's susceptible to. Now it's time to build the treatment plan. And when you're dealing with an established bone infection, just guessing with empiric therapy often isn't going to cut it. Let's use Pseudomonas aeruginosa as our case study again. Treating the osteomyelitis it causes is a marathon, not a sprint. You're looking at prolonged, high-dose therapy. A standard approach involves at least 6 weeks of a powerful anti-pseudomonal drug, maybe intravenous ceftazidime or a high-dose oral antibiotic like ciprofloxacin. And the dosing isn't one size fits all. You have to adapt based on what the lab tells you. If the bug shows intermediate sensitivity to a drug like ceftazidime, the standard dose just won't be enough. The strategy then has to shift, often to a higher dose given as a continuous infusion. The goal is to keep the drug level in the body consistently above the amount needed to kill the bacteria, overcoming that relative resistance. And of course, this same kind of thinking applies to the other pathogens you might run into. For a Staph aureus bone infection, you'll need a high-dose, frequently administered IV antibiotic like flucloxacillin for several weeks. And if you find a fungus like Candida, especially after surgery, the whole playbook changes to an antifungal like fluconazole, again for an extended period.
Now, it is absolutely critical to point out that treating children is not just a matter of scaling down adult doses. When it comes to recurrent middle ear infections in kids, the state that can lead to mastoiditis, the evidence actually argues against several common therapies. Things like routine preventative antibiotics, corticosteroids, and antihistamines are generally not recommended because the potential harms, like promoting antibiotic resistance, aren't justified by the limited evidence that they actually help. So we've been focused on the individual patient, but we also have to zoom out and consider the public health angle. This involves both preventing infections in the first place and mandatory surveillance. We can talk all day about these complex pathogens and high-tech treatments, but we can never forget the basics. Prevention still boils down to these foundational principles of infection control. Even in the most specialized clinics, strict hand hygiene, proper aseptic technique, and following sterilization protocols are still the #1 most effective way to stop infections before they can even start.
And to really hammer home how seriously the public health side is taken, check this out. In many places, it only takes 2 linked cases of community-acquired MRSA to trigger a mandatory report to public health authorities. 2. That is an incredibly low threshold, and it shows just how high a priority it is to track and control the spread of these highly resistant organisms.
Okay, finally, let's talk about the stakes. What happens when treatment fails, or if the diagnosis is delayed? The infection can set off a really severe cascade of events. Think of it like a terrible chain reaction, especially with a pathogen like S. aureus. A simple, localized infection can burrow deeper into the tissue, then into the bone itself, causing osteomyelitis. From there, it can break into the bloodstream, a state called bacteremia. And once it's in the blood, it can travel anywhere in the body, setting up new pockets of infection, like septic arthritis in a joint. It's a truly life-threatening progression.
So this deep dive into diagnostics and antibiotics represents our best practices right now. But we all know the game is changing. Bacteria are evolving and resistance is growing. And that leaves us with a critical, forward-looking question. As our current drugs become less effective, what non-antimicrobial strategies, things like phage therapy or modulating the immune system, will have to become central to how we manage these severe infections in the future?